So I feel it's very evident when the fellow or PhD students are on their own with no backup, with no support, to ones that have all that kind of support.
Welcome to the sOOPR podcast, designed for medical trainees looking to take time out of training for a clinical research fellowship in the UK. Each week, we'll bring you a 15-minute discussion with a leading expert in the UK medical research process, or from a successful research fellow sharing what they wish they'd known before they'd taken their time out. I'm your host, Nikhil Alawalia, and on behalf of the British Junior Cardiology Association and with support from the BHF Clinical Research Collaborative, we're proud to bring you this series. I'm pleased today to be joined by Dr. Mays Jawad. Dr. Jawad, would you tell us a little bit about yourself?
Yes, so I'm currently employed by Barts Health, but I work in the joint clinical, joint research management office. So that's both Barts Health and Queen Mary. I'm a research governance operations manager. I've been in this post for 3.5 years, I think. But before that, I've been in other research manager posts from Guy's and St. Thomas, Moorfields, as a trial manager at UCL. And before that, I had an academic life. So I was an academic and did my PhD in genetics and postdoc as well, that sort of thing.
Can you tell me a little bit about what being a sponsor involves?
Yes, absolutely. So according to the UK policy framework for health and social care, a sponsor sort of takes the overall responsibility for the setup, the management of the study, and then ultimately the successful and safe delivery and reporting and dissemination of results. So basically, if you think of it, the sponsor will provide the insurance indemnity. They need to make sure that the project being set up is compliant to any of the regulations, compliant with good clinical practice, for instance, will have the appropriate funding, has the appropriate regulatory approvals in place. So they take on all of that responsibility. So that's what the sponsor does. Usually the sponsor will be the substantive employer of the chief investigator. But in the case of students, it will be their academic organization or institute that is supporting with their study. The first step would be getting your funding, getting the sponsorship review, and then supporting you with the submissions to the regulators, okay? So the regulators, so the HRA, will not even look at your project if it wasn't signed off by a sponsor. So that's why the sponsorship comes first, and then you submit to the regulators. Now, the HRA is all about assessment of governance and legal compliance. So what we tend to do in the sponsorship review is we have lovely templates for you, yeah? We ensure our templates will include everything that the HRA or an ethics committee or the MHRA or whatever regulation you want is actually form part of your application, so it can pass first time and you'll have the least amount of feedback required. Okay, so I haven't sort of emphasized the amount of information we have, and maybe it's probably overwhelming for some researchers that are not used to actually going through the paperwork and everything. But we've got a very good JERMO website. So if you just Google JERMO, we've got very good guidance documents over there. We've got frequently asked questions. Our sponsorship process and what we've done is try and create a proportionate review process so that, for instance, if you're setting up an observational study, I'm not going to have the same requirements as a sponsor if you are setting up a drug trial, for instance.
Yeah.
We split up our review process into 3 different types. One is your MHRA regulated studies. So that would be device clinical investigations or clinical investigation medicinal products. These are the drug ones. Or they would be intervention. So for instance, they will change standard practice or treatment for a patient. And then those ones that are literally just observational questionnaire types. So depending on your study type, those are the types of paperwork you're going to be needed to complete. And we have sort of checklists for that. So you know, oh, okay, I will need this document. I will need this document, this document. This will help you navigate through all the paperwork that you require. We receive those, we complete a risk assessment, which is the sponsorship review. Then we confirm, yes, Barts Health or Queen Mary can sponsor your study, depending on your substantive employer or academic institute. And then we allow you to go and submit to the regulators. Hopefully by then you have everything that the regulators would require, and therefore it can fly through. I say fly through, you still get some feedback. So on average for a non-commercial study, it would be receiving HRA approval within around 66 days.
Okay.
Once you've submitted to the Health Research Authority. Yeah. And remember, HRA is sort of the overall assessment of governance and sort of legal compliance. Yeah. Within that sits ethics. Yeah. Ethics is independent of the sponsor, the funder. It puts the patients at the heart of their review, which is what you're after. So that's why we suggest getting a PPI group, a focus group. So this is patient involvement in there. Sometimes we learn so much about how we retain our patients, how we can deliver successfully and safely by actually talking to our patients. Can you really come in at 8 a.m. on the tube in the London Underground to expect treatment? And there's some things that are really useful when you talk to our patient groups. And so that's what ethics does. Ethics looks at the patients, challenges you about whether you've actually thought really about the patients themselves and weighing the risk and the benefits to the patients. So that's what the ethics is. HRA, the Health Research Authority, will not give you approval without having the ethics approval in place, for instance.
Sure.
Then we have other approvals. So if, as I said, if it was MHRA regulated study, you still will need to submit to the MHRA for their own approval as well. Okay. And again, HRA will be the last approval in place. It will ensure you've got everything else in place. The HRA will also be looking out for anything required for tissues, for instance, HTA regulations, GDPR for anything to do with data, that sort of thing. And they check compliance against that. They will obviously challenge us as a sponsor. Do you have an appropriate database? Are you going to put data transfer agreements? What agreements would you have with, for instance, the other sites that you may have? How appropriate are your study teams? That's what we are assuring when we're providing sponsorship. That don't worry, that part is covered. We're absolutely sure about the insurance, the indemnity, the qualifications of the study team, that sort of thing. Okay. Does that sort of make it a bit clearer on the distinction between us and?
So would a good example be something like if you're almost the partner or the solicitor or the lawyer representing the study, going through all the different checks and process. So the sponsor sits more on their fellow's side and supports them through that process.
Definitely we're on your side, remember, because at the end of the day, it's a reputational risk for us when we're undertaking any research, and we want very good quality research reaching the regulators. So as I said, I would come in equipped, have the appropriate training, having looked at our website, familiarize yourself with the SOPs. We've got 3 for sponsorship, depending, as I said, about your study type, but just pick up the phone or make a meeting with any of our governance officers to come and have a look through your paperwork. Now, we formally will start the review process of your paperwork once we've received your full your full study package. The checklist that I said, and that's when it gets allocated to a governance officer, and that's when the review process starts. It obviously, in terms of, I would love to receive a good application. And really that actually happens when someone's actually done it in the past. So they're familiar with, I'm sure I'm going to get feedback. I might as well include this from now. We also have the problem of consistency in the paperwork. So let's say, for instance, you're busy in the clinic, you're going to have one evening to start doing, and then 2 weeks later, you're going to finish an IRAS form, let's say. And then what you put the information here is going to be very different because your mindset is very different. And I would say, try and do them all at the same time, because what is the bugbear in ethics committees? You've said you're going to let participants have 24 hours to consider, but here you said you're going to approach them as soon as they get into clinic. Which one is it? So it's that lack of consistency. And I would also say, I think what delays things sometimes is when we give feedback, we don't hear anything from the researcher. And it's like, you said this was urgent. You've been chasing us. We've now given it to you, but where are you? So I'm having to sometimes say, are you still interested in this project? Because we've got so many others to get on with. So, those are kind of the things I would say, but engagement, being on top of things, a good application really helps. And you know what? Set a meeting with the governance officer. Sometimes this email back and forth doesn't help. And obviously people are still, a lot of them working remotely. So I would say just thrash it out in one meeting so everybody's on the same page.
How much does this structure and process, how similar is it at other institutions that you've been to? Like, is this something that other center research offices like at Guy's and St Thomas's where you've been previously, is it similar?
It's similar. I would say similar in the sense that we all know what the HRA and the ethics require. Yeah, we all have our own risk assessment tools or whatever, but that's just to assess whether we can sponsor a study. I would say more the internal review process may be slightly different. Support departments, I would say engage with them as early as possible. That's everywhere. It's just, I suppose, the clinical director sign off may be different. Some people have committees or do feasibilities or whatever, and others do things differently. Overall, it's the same concept.
Great.
It depends on how much guidance they provide and how much support they provide and how big an organization is.
I mean, it obviously seems like your team have got a lot of experience and know the hoops that need to be jumped and what things can commonly go wrong. So at what stage would you advise a fellow who's wanting to come out and undertake a doctoral research to engage with their research office or someone in your team?
As early as possible. Honestly, I can't overemphasize that, because don't assume, I'll come in, I'll give them 2 weeks, they can set it up. It's just not possible because of existing workload. But I've already told you, the HRA will take minimum 66 days as it is. We will take probably an additional couple of months, but it all depends on your application. That's why I say, have a look at our JERMO website. Please have a look at it. It's got a lot of information in there, even things on what to complete in an IRAS form, things like that. It's all in there.
I now want to just focus on the relationship between the sponsor and the fellow during the research. And you said it doesn't stop and there's lots of checkpoints and things like that. Can I ask, does the sponsor get involved in the educational side of things or ensuring that happens, or the training of the fellow?
Not really. I mean, as I said, training, yes, in terms of we have our own training. You wouldn't be able to set up a project if you didn't have, for instance, GCP training, definitely. I think also we're not going to sort of leave you alone, in the sense that if we feel we've looked at your CV, you don't actually have a lot of experience, you actually do really need a mentor. The expectation is whoever is going to be signing off as a clinical director will also consider, okay, who can I put in touch with this person to actually help them or support them? That sort of thing is expected as part of your department sign off for the project. But what we would find is we've just approved your study, and then you come the next day and think, well, I've recruited my first patient and I found I can't really do this thing, or I've got this missing, or I need to add this extra step. And that's what the amendments come in. So we will help you and review the amendments. And remember, when you submit an amendment, we still need to therefore revisit the risk assessment and see, can we really still sponsor it? Has it actually increased the risk of the study or not? We may, if it's a high-risk study, we may monitor it. Annually, you have to submit progress reports. So we check those progress reports. You have to submit them to the ethics or HRA. And we also have an oversight. Okay, they said they're going to recruit 100. So far, they've only recruited 2. Are they really on track? And therefore, we come and help you and see, what is the problem? What are the blockages? What can we do? What support you require? So we will have those honest conversations. And there's no harm if you feel this is no longer feasible. It's more unethical to put patients through a project which we know we can't deliver on, or you're not even going to get your final end result or the primary output anyway. So it's fine to come to us and say, actually, I need a drastic change to this project. Can I work with you again to actually do that? And we can submit to the regulators and explain that. It's better than carrying on with a project that you know is not deliverable.
Okay, fine. And do you have that conversation early on, perhaps, with the fellow to say that something doesn't look feasible? I mean, how does that happen if you think that there's something that, not just the fellow, of course, them and the chief investigator are going for something too ambitious?
So it's sort of the responsibility doesn't just lie with us. I mean, this is the whole point of a peer review process, a really robust peer review. So I expect if it's gone through funding, stage 1 and stage 2, someone's actually really assessed that science, okay? But let's say even if it hasn't gone through, you've had an external independent reviewer. I need to establish, so what is this review? Have you incorporated all their feedback? Now, the internal review committee or your clinical director, whoever signs off the study, should also be looking at that. They should be looking at the the protocol itself. Does this make sense? Is this deliverable? And we rely on the clinical director to also have an opinion and say, that's fine. They're really experienced. They're really good. I actually really stand by this. Is really important strategically for the department, that sort of thing. So that's where we get a lot of that information from.
Okay, great. And you mentioned that you can often tell when someone who's applying has done it before because their quality of their work and the things that they include are more robust. Is there any other advice or things that you have seen in applications that make you think that this is a good application or is going to sail through the process a bit easier?
So what we do as part of our risk assessment, remember, as part of a sponsorship review, we do look at the history of the applicant. So we would be engaging with our auditor. Have you audited this team before? Have you audited this department before? We also have our QA manager does all the breaches and non-compliances. So we'd actually say, are there any breaches and non-compliances from this team? That all forms part of the risk assessment. Or let's say, for instance, oh, this is a new researcher. They've never done research before, but they're asking all the right questions. They're doing all of this appropriately. And it's that discussion with the governance. I don't have a problem with that. It's when the governance officer may say, Mace, they really don't want to do this. Of everything we're suggesting, we're trying to advise them, they're not taking on that board. I would say that's when I would say, okay, let's open the study, but let's put it, for instance, on the audit schedule. So we have also an audit schedule. And the aim is not to freak you out or anything. It's more, let's sit down, let's work with you. Remember, you are the future of research. You may be doing a simple study now, you may be doing a drug trial in the future. So if I audit you and I give you feedback, then I know you're going to improve on that. So anything that sort of red flags, then we put it on potentially the audit schedule. And that is for lone investigators, new investigators, investigators with history of critical findings, for instance. Mm-hmm. But we can guess with how the quality is. I mean, that's when you get a review quickly back from a governance officer. That's when the governance officer is very, very happy and will push it as quickly as possible because you've actually done all the legwork, which is lovely.
And so conversely, are there things that make you, you mentioned about putting it on your red flag system, is the things that fellows often do wrong or common mistakes that you see?
I suppose I think the biggest problem we have, whether it's a fellow or a PhD student, it's the supervisor support that I find maybe a bit lacking. And therefore, I feel you're left alone in a way to go through the whole system of that paperwork and bureaucracy. And what you need is actually someone to support you and help you who's done it before. You know, so I feel it's very evident when the fellow or PhD students are on their own, with no backup, with no support, to ones that have all that kind of support. A lot of the time, even the stats section is quite a difficult one. And I would have hoped that's something that you've agreed with your supervisor, and I've got that obviously in your grant application. So I think it's obvious what in terms of support there for the fellow, whether they're on their own or not.
Yeah, I mean, that's a really good point. And I think something that fellows do need to also think about when they're choosing their supervisor, because that's an important aspect. Okay, great. So just to finish off then, do you have any final bits of advice that you would give to a fellow or a PhD student who's in the early stages of their application to try and optimize their process as much as possible?
Yeah, I mean, I would say give it plenty of time. Engage very early, look at our website, do all the training that we already have ahead of time, book an appointment with us to talk about your project as well, and just be realistic. Yeah, realistic about timelines, and also set expectations with the governance officers. There's no surprises there, you know, and that's what I would actually recommend. And if there is any sort of escalations, I would say, you know, come to us, you know, anytime for us to try and understand. I know the urgency of your projects. So is everybody else's. Is quite urgent. You won't believe it. Everybody thinks it's urgent. Yeah. And it probably is.
Yeah, great. I mean, that's really useful, and I think something that we can all take away from and work on. So thanks so much for your time and all that advice. And
I hope I haven't put you off, yeah?
no, not at all. The links that you mentioned, what I'm going to do is I'm going to put them in the show notes so anyone who wants to access them. Next time on the podcast.
I know that merely obtaining a higher degree obviously has value, but for a young clinician thinking about growing their career, you have to think about how can it benefit me best.
For today's episode, I'm really pleased to be joined by Professor Rod Stables. He's the clinical lead for the British Heart Foundation Clinical Research Collaborative and also a consultant cardiologist at the Liverpool Heart and Chest Hospital. Relevant to this, he founded the Clinical Trials and Evaluation Unit at the Royal Brompton Hospital and was also the chair of the Academic and Research Committee at the British Cardiovascular Society. He holds academic appointments at the University of Liverpool and the Imperial College London